What we'd like to do now is to turn the spotlight, turn the focus to prevention and public health strategies. And of course, the big word that comes to mind, of course, screening. Different models, different approaches in so many different countries. What I'd like to do now is to call on Dr. Hilary Robbins from the International Agency for Research on Cancer, IARC, for her topic, lung cancer screening and early detection. A warm welcome for Hilary.
Good morning, everyone. My name is Hilary Robbins, and I'm an epidemiologist at the International Agency for Research on Cancer in Lyon, and I'll be talking about lung cancer screening and early detection. I'm trying all the buttons. IARC is, of course, the specialized cancer research agency of the WHO. Our mission is to conduct research on cancer prevention, but also to promote global collaboration among researchers. To this end, my team coordinates the Lung Cancer Cohort Consortium, which is truly the engine that drives our lung cancer research. The LC3 brings together data and biospecimens from 25 population cohorts around the world. These are epidemiological prospective cohorts. Taken all together, there are 3 million participants in this consortium, among whom 69,000 lung cancer cases developed during the follow-up. And the resource is available to non-commercial researchers. We have an access policy that you can access at the website. Lung cancer remains the leading cause of cancer death worldwide, as you all know, with the main cause of this being tobacco use around the world. But when we look at the epidemiology of lung cancer and compare with other poor prognosis cancers, we see that lung cancer has what I like to call the epidemiological fingerprint of a screenable cancer type. So a cancer type where we could make an important difference by cancer screening. This fingerprint has two components. The first is a strong gradient in survival across stages. So we see that for stage 4 lung cancers, survival over 5 years is only about 20%, but when we compare with stage 1, we see survival of about 90% over 5 years. So we know that if we can shift diagnosis from late to early stage, we should be able to reduce mortality. The second component of this fingerprint is the sort of current stage distribution of lung cancers, which is strongly dominated by late stage. So among lung cancers in high-income countries, about half of them are diagnosed at stage 4 and another 20 to 25% at stage 3. So when we have this scenario, we know that if we could shift the diagnosis from late stage to early stage, we should be able to reduce mortality from these cancers at the population level. In lung cancer, we are very lucky since 2011 because we have a tool with which to achieve this, which is low-dose CT screening. We have 2 very large randomized clinical trials showing that low-dose CT screening can reduce lung cancer mortality among people with a heavy smoking history. The first of these was the National Lung Screening Trial in the US, which was published in 2011 and showed a 20% reduction in lung cancer mortality with low-dose CT as compared with chest X-ray. This result was replicated by the Nelson trial in Europe in 2020, which showed a 24% reduction in lung cancer mortality in men and an even larger reduction of 33% in women. Any disease screening program has benefits and harms. What we hope is that there's benefit, there are always harms, and we must find the balance. With lung cancer screening, we know that we can prevent some deaths from lung cancer, but we must balance this against the harms, which include false positives, potential overdiagnosis and overtreatment, diagnostic complications, radiation exposure, and the stress and worry. For lung cancer screening, balancing benefits with harms is a story about risk assessment. I'm showing you here a reanalysis of data from the National Lung Screening Trial, which estimated how many lung cancer deaths were prevented in different groups according to their individual risk at baseline, which was predicted based on their age, detailed smoking history, family history of lung cancer, etc. When we look at the very lowest risk group, we see that there were very few deaths prevented in this group, even though these were people who had more than 30 pack years of smoking. On the other side, the prevented lung cancer deaths were very strongly concentrated in the highest risk participants. So when we think about lung cancer screening, we immediately must think about the pre-screening risk assessment and trying to target screening to the people at highest risk. I don't have time to tell you very much about the implementation of lung cancer around the world, but suffice to say that the implementation is advancing globally. There are cost-effectiveness studies being done in many settings, although these have a very wide range of results. There are national programs implemented or announced in various high-income and upper-middle-income countries. And when we think about implementation studies and national pilots, these are happening in many, many high and middle-income settings. If you want to explore the current status of lung cancer screening around the world, I highly recommend this interactive map from the Lung Cancer Policy Network, which was updated, I think, just in the last couple of months. I'm going to tell you a bit about sort of research directions and controversies and novel technologies in lung cancer screening. But before I do that, I want to say very forcefully that more important than using fancy technologies is to implement these sort of best practices if we want to achieve population benefit from lung cancer screening. The first is to integrate smoking cessation into any lung cancer screening program. Lung cancer screening should never happen at the expense of tobacco control. Tobacco control remains the most important way to reduce the burden of lung cancer. We have to ensure high uptake and retention, enforce multidisciplinary review of nodules that are detected on low-dose CT. They're very, very commonly identified. Use risk communication tools for participant decision-making. Employed a dedicated program manager to ensure the sort of comprehensive flow of participants across the program steps, ensure aspects of financing workflow, governance, as well as technical specifications and quality control. So I'll move now into the fancier stuff, research directions and controversies in lung cancer screening. The first is, how should we define the eligible population? When we look around the world and we look at the original randomized clinical trials that were done in lung cancer screening, what we've typically done is applied thresholds of age and pack years to decide who should be screened. And sometimes we also put a threshold on time since cessation. And this is what's being done in most of the national programs and pilots that are being implemented now. But there's an interesting story in the United Kingdom because the UK sort of leapfrogged, and from the very beginning, they used detailed risk prediction models to decide who should be screened. These risk prediction models take very detailed information on individual smoking history, family history of lung cancer, and health history. They output an individual personal probability of being diagnosed with lung cancer. They draw a threshold and they screen people above the threshold. And this is a way to identify a higher number of lung cancer cases while still screening the same number of people. But these rules for how to define the eligible population are a very intense discussion every time a new national program is designed. And my team, we did a modeling study of lung cancer screening in France. And we found that examining the population of people with a smoking history between age 50 and 74, if we screened everyone, this would be about 13 million people, and we could potentially prevent 21,000 lung cancer deaths over the period of 5 years. Of course, we're not going to screen everyone. So let's say we apply the screening criteria from the European Nelson trial. These are based on how many cigarettes were smoked per day, smoking duration, and time since cessation. This would screen 20% of those individuals, but identify 46% of those preventable lung cancer deaths over 5 years. If we instead use a detailed risk prediction model to choose a population of exactly the same size, we can increase that proportion of preventable lung cancer deaths detected from 46% to 54%. So this is just one way to illustrate how we can make these screening criteria more efficient. Another increasing controversy is, should people who never smoked be offered screening? I told you at the beginning that lung cancer screening is a story about risk assessment. These are data from our consortium showing the cumulative, more or less lifetime risk of lung cancer diagnosis. For people who smoked more than 20 pack years, we see a lifetime risk of about 9%. For people who smoked but less than 20 pack years, there's a risk of about 2%. And when we look at the cumulative risk among people who never smoked, this is about 0.8%. So the task here, which is very difficult, is to pluck out from these population of people who never smoked the very small number who have sufficiently high risk to have net benefit from screening. And this is not an easy job. The other concern with screening people who never smoked is about overdiagnosis. There's a lot of emerging data from East Asia in which screening of people who never smoked is occurring, and lung cancer trends of mortality and incidence over time show patterns associated with overdiagnosis, which we have yet to fully understand. Third one, what is the role of artificial intelligence? AI in lung cancer screening can take many forms, but the most important one is applying algorithms to the actual low-dose CT images to try to assess the risk of lung cancer. And there's many different things we can do with this technology. We can reduce the radiation dose to the participant. We can improve nodule management by using AI as either a second or first reader or as a companion to the radiologist. We can potentially identify very low-risk people who can wait longer in between their screens. But there's really quite a bit of research needed because there's many algorithms proposed. We don't know which one is the best. They're not often externally validated, and we don't understand their impact on clinical decisions in radiologist capacity. And finally, what is the role of biomarkers? This is an area where my team is working quite intensively. We can envision using biomarkers at many different steps in the screening process. We can try to improve risk assessment and screening eligibility, which is where we're working in particular. We can try to inform nodule management, and we can again try to personalize the length of screening intervals by improving this risk assessment at each step in the screening pathway. In our research, we assembled biospecimens from 6 cohorts in the lung cancer cohort consortium. These were 731 case control pairs where the cases had blood taken up to 3 years before their diagnosis. We scanned associations for about 1,200 proteins and found 36 that were robustly associated with lung cancer risk. We subsequently included these on a customized panel aiming to improve pre-screening lung cancer risk assessment. And we brought this panel to a very large phase of independent algorithm development and a final validation with data that had never seen an earlier phase of the study. These data are from the final validation. So what we see is if we take this sort of broad population of people with a smoking history, if we apply the US PSTF, which is the US task force criteria for screening, we would screen 25% of that population. And that allows us to identify 63% of the lung cancers occurring over the next year. If we instead use a smoking-based risk prediction model, we can increase that to 70%. And if we then add these protein biomarkers into the risk assessment, we can go even further all the way up to 85%, still while screening the same number of people. So again, it's a story about trying to improve the efficiency of the screening program, but of course, many practical and cost questions remain about how to potentially use these biomarkers. So to conclude, of course, we've seen that in randomized clinical trials, low-dose CT screening can reduce lung cancer mortality among people at high risk. And as such, implementation is advancing worldwide, but many questions remain about defining the eligible population, whether we should screen people who never smoked, using AI, using biomarkers, and most importantly, screening should only be done if it can be done well. And before I conclude, I want to thank my team. At IARC, I co-lead the Risk Assessment and Early Detection team. We're a group of 16 people from 14 different countries, and all of the work that I presented was co-led with Matthias Johansson, who is from Sweden. I want to particularly thank Karine Alcala from France, Xiaoshuang Fang from China, Hannah Zahed from Lebanon, and Chaima Al-Wahidi from Palestine, who made very important contributions to the work that I presented. Thank you very much.
Dr. Robbins, thank you very much. And actually, if you could stay on the stage, join me here. Different cancer now. We have lung cancer. We're now going to talk about gastric cancer, and we'll have questions after our second presentation. Dr. Kui-Son Choi, Department of Cancer Control and Population Health at the National Cancer Center, South Korea, and the Graduate School of Cancer Science. Thank you very much.
Thank you for the kind introduction. It's a great honor to be here today to discuss improving the prognosis of gastric cancer screening with a particular focus in Korea. This one. Yeah. This is an outline of my presentation. First, I will introduce the global trends and burden of gastric cancer, and next I will detail the gastric cancer screening program in Korea. Then I will briefly discuss ongoing initiative gastric cancer prevention, and finally I will close my presentation with summary notes. As you know, gastric cancer remains a major global burden. In 2022, the fifth most common cancer worldwide. Gastric cancer is the fifth most common cancer worldwide, following lung, breast, colorectal, and prostate cancer, with nearly 1 billion new cases. And also, gastric cancer is the third leading cause of cancer-related deaths after lung and colorectal cancer, with around 660,000 each year. Yeah, and as you can see in this figure, gastric cancer shows the large geographical variation in its epidemiology. It is most common in Asia, accounting for 71% of gastric cancer cases and 70% of gastric cancer deaths. Yes, and this figure compares global age standardized gastric cancer incidence and mortality worldwide. As you see in this figure, Mongolia has the highest incidence and mortality, and Japan ranks second, and Korea in third place in incidence. However, both Japan and Korea demonstrate significantly lower mortality rate compared with other countries, and this is largely due to their national early detection efforts. Gastric cancer mortality in both Korea and Japan has dropped sharply following the introduction of screening programs. So as you can see in this figure, this graph shows trends of gastric cancer incidence and mortality, and gastric cancer incidence has been steadily declining in Korea, in Japan, and China. However, the mortality rate have been declining much more rapidly than incidence rate, and specifically Korea has shown a lower gastric cancer mortality compared to Japan since in 2014. Although some Asian countries, such as Japan and Korea, have been significant declines in gastric cancer incidence mortality over the decades, the number of cases is expected to increase due to the aging population. It is projected to reach 1.8 billion and 1.3 billion deaths by 2050. Thus, gastric cancer remains a significant global health burden. To tackle this, Korean government launched the National Cancer Screening Program, offering free or subsidized screening for 6 types of cancer. Specifically for the gastric cancer, individuals aged 40 and older have been offered either endoscopy or gastrointestinal series, also known as photofluorography or radiography, every 2 years since 2002. And while upper GIS was used for gastric cancer screening in Japan, Korea was the first country to introduce endoscopy as a population-based screening modality. Since the program started, participation rate has dramatically increased from 7% in 2002 to 57% in 2019, and currently about 8.2 billion get screened annually. And initially, upper GIS was more frequently used, but endoscopy gradually became more common, and now endoscopy, the pink one, is the dominant method. It's used in about 90% of all screenings. Yes. Gastric cancer screening has facilitated the early detection of gastric cancer in Korea. Especially, we found that endoscopy is much more effective than upper GIS in detecting early gastric cancer. People who had endoscopy were 2.1 times more likely to be diagnosed with localized gastric cancer, while those who had upper GIS were 1.2 times more likely compared to those not screened. And as the screening rate have risen in the left side of the figure, the proportion of cases diagnosed at early stage has grown. This figure shows trends in gastric cancer screening rate, not only the organized, but also the opportunistic screening. It has significantly increased from 39% in 2004 to 77% in 2023. As a result, the proportion of localized stage cases have increased from 52% in 2005 to 70% in 2022. It means in Korea, nearly 70% of gastric cancer patients are now diagnosed at early stage. And gastric cancer screening has also been effective in reducing gastric cancer mortality. We conducted a nested case control study using the data from the National Cancer Screening Program, which includes 16.6 million people. From this cancer-free cohort, we identified the individual who had died from gastric cancer as cases and matched them with a similar individual who was still alive as control, and we compared the risk of death from gastric cancer. So this is the result. This study showed that endoscopic screening, the right side of the figure, showed the lowered risk of gastric cancer death by 49% in people aged between 40 to 74. In contrast, apogee was only reduced 5% of reduction. These findings have been supported by recent meta-analysis. It was reported that radiographic screening did not significantly reduce gastric cancer deaths, no matter which analysis method was used, per protocol or intention to screen. In contrast, endoscopic screening was shown to reduce gastric cancer deaths by around 48%. However, the intention to screen analysis did not show a statistically significant result. That's likely because the overall impact at the program level was limited due to low participation rate. Therefore, given the clear mortality benefit in reducing mortality through gastric cancer screening and the high burden of gastric cancer in East Asia, it is important to encourage higher participation in screening. And as a result of the National Cancer Screening Program in Korea, the proportion of early-stage gastric cancer, T1A and T1B, has steadily increased, as you see in this figure. Approximately 67% of all gastric cancer cases were diagnosed as stage 1. And this shift has facilitated less invasive treatment approach. This figure shows trends of treatment modality in Korea. The proportion of endoscopic submucosal dissection, ESD, has steadily increased, while surgical treatment has gradually declined. So in 2019, 1/3 of gastric cancer patients in Korea were treated by ESD. And as a result, the 5-year survival rate has significantly improved from 52 to 78. And for the localized stage gastric cancer, the 5-year survival rate is as high as 97. It is the highest in the world. And actually, according to the Concord International Cancer Survival Study between 2010 and 2013, the 5-year survival rate was 69 in Korea compared to 60 in Japan, 36% in China, and 33% in both the US and Germany. And notably, as you can see this figure, the survival gap between Korea and other countries has continued to widen over the time. And this graph shows international comparison of gastric cancer incidence versus mortality from IRC data. Each dot represents a country and each color indicates a continent. For example, green represents countries in Asia, and you can see some outliers such as Japan and Korea. This country represents with relatively low mortality rate among those with similar incidence rates. Also, we examine the mortality to incidence MI ratio. This is a very important indicator in cancer epidemiology. It shows the proportion of deaths relative to new cancer cases. Among the 7 countries we compared, Korea has the lowest MI ratio. Despite of this significant progress, Korea still faces a high incidence of gastric cancer. A major contributing factor is H. pylori infection, which is responsible for 80 to 90% of non-cardiac gastric cancer cases. And H. pylori infection rate especially high in Asia, around 80% in Mongolia, 70% in Vietnam, and 55% in Korea, and about 50% in Japan, while the global average is around 44%. But fortunately, H. pylori infection is an easily modifiable risk factor. Eradicating H. pylori can help prevent development of gastric cancer. And as you can see, a systematic review showed that eradicating H. pylori in healthy adults significantly reduced gastric cancer incidence by 46% and deaths by 39%. And this is a recently published paper, a prospective randomized controlled trial in China. They followed H. pylori infected individual for 26 years, and asymptomatic individuals were randomly assigned to receive either standard triple therapy to treat H. pylori or a placebo, and they were followed until the end of 2020. And this study reported that those who received H. pylori treatment have a 43% lower incidence of gastric cancer, and more obvious, 63% of risk reduction was observed among those without pre-malignant gastric lesions. And this study suggests that H. pylori eradication can provide long-term protection against gastric cancer, especially in high-risk population without early precancerous regions. Also in Korea, a randomized controlled trial named the HELPER study is currently being conducted in collaboration with the IARC to evaluate the effectiveness of H. pylori eradication. This study is assessing whether H. pylori treatment can reduce the risk of gastric cancer in the general population aged 40 to 65 years. They are eligible for the National Cancer Screening Program. So far, over the 12,000 individuals have been enrolled, and among them, H. pylori infected participants were randomly assigned to either eradication therapy or placebo and third non-infected group. And all participants will be followed until 2029 to monitor gastric cancer development. In Europe, gastric cancer remains one of the poorly prognosed types of cancer, and also there is a significant geographical variation in gastric cancer burden with poor survival. Especially Latvia and Lithuania, they showed a relatively high incidence in gastric cancer. So to address this, the EU has taken an active role in the fight against gastric cancer by implementing the Beating Cancer Plan launched in 2021. And this GI Star, Eurohelican, and TOGAS, this initiative focuses on improving prevention, treatment, and care across member states, recognizing the importance of early detection. So this is the last slide. While gastric cancer incidence is declining worldwide, East Asia still has the highest burden. Korea and Japan have a high gastric cancer incidence but significantly lower mortality rate, reflecting the effective early detection and treatment. In Korea, nearly 70% of gastric cancer cases are diagnosed in an early stage and reaching the highest 5-year survival rate in the world. And Korea's high gastric cancer survival and low MI ratio highlight the importance of screening. And finally, well-designed screening and preventive strategy for reducing H. pylori infection provide a key opportunity to reduce the gastric cancer burden. Okay, thank you for your attention.
Thank you very much, Dr. Kui-Son Choi. Please join us for some questions. And I saw hands went up straight away after Dr. Robbins. Yes, some questions straight from the audience here. Just wait for the microphone. Here we go.
Dr. Robbins, I really enjoyed your work very much. Now the work has changed a little bit, in particular in our United States of America, in the sense that there is a very large increase of vaping, not only vaping tobacco, vaping cannabis, vaping. There is vaping even without anything. Is there anything, or is too premature, is there anything that you can tell us about that?
This is very difficult to study well yet. There's a few reasons. What we need is sort of robust prospective cohort data in which we have collected detailed information on vaping at enrollment and then followed people over time. So that sort of data is just beginning to mature now. So that's the first problem. The second problem is disentangling tobacco use, the effects of tobacco use from the effects of vaping, because they're very closely correlated, and people use one, they use the other, they switch back and forth. Whether we know about this as they are being followed over time, most of the time, no. So it's tricky to identify the cancer effects because it's very difficult to study. What we know is that for sure it is better not to vape than to vape. So this is, an enormous challenge is preventing the use of these products among people who did not use any tobacco products at the start.
So work in progress on this point, I can imagine, work in progress. Thank you very much. Another question from the room.
I have a couple of questions. One for Dr. Robbins. In terms of the increasing incidence of lung cancer, peripheral adenocarcinomas in younger women, is there any signatures that are available that might help you enrich in that population?
It's really challenging to understand if this is actually happening. In fact, if this is actually happening in younger women specifically, and in particular whether it's a phenomenon among people who never smoked, because in cancer registry data we don't have smoking status. So if we look at registry data in SEER, in the US data, for example, we don't actually see increasing rates of lung cancer among young people overall. But because we know the smoking trends are changing over time, we can't say for sure whether they're going up or down in smokers or up or down in never smokers. So this is really, if you talk to clinicians, they say, I have more of these people coming into my clinic. So we're struggling as epidemiologists to understand what's happening. The increase in adenocarcinoma is definitely real. And it's difficult, again, to sort of disentangle the different influences, in particular the influence of air pollution on these trends. In our consortium data from the LC3, which I showed you, we do not see these sex differences among never smokers, which is quite striking. We see if we restrict to never smokers, we see very similar incidence of lung cancer between males and females, including in Eastern Asia, but we see much higher rates of lung cancer among never smokers in Eastern Asia compared with the US and Europe. So it's a difficult story from an epidemiological perspective.
Interesting. Yeah, it is. This whole field is very challenging, I agree. And thank you for your data. My next question, if I may be permitted, for Dr. Choi. I'm a GI pathologist. I was shocked to hear that everyone above 40 gets endoscopic surveillance in Korea. That would break the bank in the US. I can't imagine that happening. There is no way that would happen in the United States. But one question I had for you was, what about, you talked about HP. I'm assuming then that Helicobacter is in fact the major driver in those cases, except for maybe a subset. Why not enrich the population with a Helicobacter screening test, some breath test or something first before you screen everyone? I'm actually surprised that that's not being done.
Yes, thank you for the questions. You must consider the healthcare system. Healthcare system in United States and Korea is totally different. So endoscopic screening in Korea is much cheaper than USA. It costs around $40 per, $40.
Oh.
Yeah.
They're moving to Seoul.
Yeah, it's quite cheap. So that is the one reason why the Korean provide endoscopy for the whole population over age 40 or over. But the combination with H. pylori eradication is very good suggestion. So that's why we just initiated some randomized controlled trial to provide the H. pylori eradication programs. So if we combine H. pylori eradication plus screening, then we can modify our screening strategy. For example, at this moment, we provide endoscopy every 2 years, but when you combine H. pylori eradication program and the screening, we can lengthen the screening interval. So that kind of screening strategy we are considering now. Thank you.
We're moving to Seoul, as we said. Thank you very much. Another question here at the top, and then maybe one more question here on the left. As you want.
Hello. My question is to Dr. Son Choi from Korea. Have you ever heard, in France we are beginning, have you ever heard about anti-inflammatory diet? For all the GI cancers, and it is just a Mediterranean diet or Greek diet.
Anti-inflammatory diet.
Yeah. Dietary is one of the very high association with the gastric cancer development, especially in Korean and Asian country. They intake a lot of salty food, so that's why the Asian country reported high incidence. And that kinds of anti-inflammatory diet and some healthy diet can reduce the risk of the gastric cancer, I think, yes. So prevention is very important, especially focuses on the diet. It can reduce the gastric cancer incidence, I think, yeah.
Just avoid animal proteins.
Okay, thank you very much. That's a discussion to have over lunch, isn't it, afterwards? That's a discussion to have over lunch. Another question here on the left.
Thank you very much. Delaney Quarter from Prevention United CC. I have a question for Dr. Choi. As you can imagine, the screening and prevention in Europe is very diverse. And congratulations, obviously, on the screening for the 6 cancer types. But I have an operational question. Who is actually dealing with the implementation? Because we have strategies as well, but we are lacking the implementation. And what do I mean by that? Is the hospital that's doing the screening, or do you have like a separate structure that's screening the population?
So, could you clearly ask a question once again? So, her question is that...
Yeah, if you wanted to repeat the question, it's about the structure.
Who's organizing the program, cancer screening program? Yeah. So in Korea, we have national insurance system. So National Health Insurance Corporation actually organized the whole screening program. And for the gastric cancer screening, we have a lot of screening facility in Korea. So usually gastroenterologists, they provide endoscopic screening for the people, yes. That is your...
So it's a multi-layered structure, right down to the specialists and the clinics.
Yeah, right. So from the screening unit, the people receive the screening, and then they have some abnormal findings, then they refer to the tertiary hospital, teaching hospital to get the treatment.
Interesting. And we can have a private discussion about the actual nitty-gritty of the structure. Thank you very much. I think that is enough for the questions. We have another session before lunch. But thank you very much. Fascinating insights. Lots of questions we could ask. So don't hesitate during lunch if you want to further your discussions. Thank you very much, Dr. Robbins, and also Dr. Kui San Choi. Thank you very much.